Is there a possibility that this virus was here prior to the first report, like in December or January?
You mean COVID-19
Yes.
or coronavirus?
Yes, COVID-19.
All right, coronavirus is a big category of different kinds of viruses,
Right.
and we've talked about
We
that.
discussed in the first video.
Coronavirus has a very strange characteristic. It's a single-strand RNA, and if it finds a bit of RNA material or DNA material in a cellular environment, it has the habit of incorporating that into its own genome, making it capable of mutation in a heartbeat.
Oh, wow.
And indeed, one of the theories as to why COVID-19 happened was that it was a zoonotic or animal virus first. These are not uniquely human. It encountered something in an animal species, a dog, a cat, a bat, a cow, any animal, picked up another type of genetic material, which, like I said, they have that characteristic, and mutated into this COVID-19 with more lethal characteristics than the normal benign coronavirus. The interesting thing is SARS was the same kind of a situation in the early 2000s, 2004, if I remember correctly, or 3. And at that time, they projected that virus to have a lethality of between 6 and 8%, which is more than the COVID-19. So to ask when did it start and how did it start and all the rest of that is certainly a speculation.
That's a loaded question.
And and did it happen before people got sick or people became symptomatic? It might have.
Yeah.
But it might not have.
Well, I already know people personally that have tested positive who had it in February.
And maybe even beyond that, if we go to the Chinese
Well,
data, and there was evidence all the way back into November. I think it was our military that picked up, the biological defense force that we now have, picked up the potential for a mutation that would be biologically hazardous. They might not have proven it, but they were suspicious.
So why didn't SARS take over the population like this?
Transmissibility probably was not as great, or it didn't find a host large enough to propagate itself. You have to have a vulnerable host along with the parasitic tendency. It can be something that's highly contagious, but that may be different from its infectivity, from its infectiousness. And that also may be different from its ability to cause morbidity and mortality. In other words, how lethal, how devastating it is. All of those elements are part of the natural selection for the virus and its ecology, just as much as we have an immune memory to most of the things we have been exposed to. We might have something slip just because there's a genetic variation. The disease then becomes manifest again, and then it goes to sleep as our immune systems catch up to that signaling.
Right.
There is an evolutionary process that's constantly occurring.
It's so fascinating.
So to say when did it start, and was there evidence for its existence before date X, Y, or Z?
Right.
It's kind of a moot point. You deal with the reality now and go from there.
Totally.
Yeah.
That's so interesting. Saying this is from the same question. Some are saying it's possible that many of us that had upper respiratory infections may have actually had COVID-19.
That's true.
It's possible, right?
Oh, yeah. We have been greeted daily and almost hourly with the statistics of what's going on, how many people are sick, how many people have died, how many are hospitalized, etc. Right. The statistical assessment says something about the herd, says something about the whole group. It won't be until we have the serology or the tests for the entire population that we will know what the actual incidence of exposure and response is. You might have a case, and especially true in certain age groups. We can go with the young right now. Apparently, they are much more resistant than the elderly.
Yep, we had talked about this last
But
time.
they have to have the same level of exposure as the elderly. It would be a different world, a different community, a different universe where you would have one group being exposed more than another if it's a randomized and equitable process.
Right.
So the likelihood is you'll find antibodies or you'll find evidence in an immune response of that exposure. Now, why everybody doesn't get sick the same way and why some people have insignificant symptoms, others have some moderate symptoms, and others have severe symptoms, all of that's a matter of study. But we won't know about it until we've completed the full cycle of exposure risk and measurement, and then look backward at those statistics. Then we'll know actually how bad the disease was or how moderate it was.
Right.
You know?
Absolutely. All right. If a person gets a mild case and they get better, can they get a relapse or be reinfected? Would that require a mutation, and have any mutations happened yet?
Second part of that question is a little bit, it's a little bit inaccurate. I wouldn't,
Okay.
are we talking about, do you have to have another COVID-21?
Right. I think, yeah. I think
But so let's leave that part out.
Yeah. Well, you kind of just talked about the RNA properties of coronavirus
Right.
and how
and its
easy
ability
it is
to change its genetic behavior.
Yeah.
But the truth of whether or not a person has a mild case and then becomes immune to it, that one is still a matter of study.
Okay.
How long will the immunity last? What type of immunity is it? There are right now treatment paradigms, treatment protocol, where the patients who have recovered from coronavirus, where their serum is being harvested and given as a
Their plasma.
as not just they've done it with plasma cells, they've done it as a sort of a cellular donation, but just using the gamma globulin fraction back to patients who are desperately ill, quite frankly. Similar to what was done for polio. Polio, gamma globulin was the name of the shot that was given to somebody who had exposure to polio, but was known not to have any defenses, or a child who you were worried about. They also did it with hepatitis and several other viral diseases. Having said that, it's unclear how long immunity will last, how deep it becomes, and whether a person is immediately at risk. But the probability is, if you just take your own experience with a cold, once you've had a cold, there's a grace period following the recovery when you're not really likely to get another one. And that's pretty much what will happen with this coronavirus, because that's what's always happened with coronaviruses.
Right. If something different happened, it would be very, very...
It would be a different universe. It's
Right.
That's not what's going on.
Okay, good to know. Okay, let's see. This one's kind of specific. I saw my first mosquito in my living room today. Can the virus be transferred via blood? Also, countries on the southern hemisphere are approaching colder weather. Are we going to see those countries more at risk? How much does weather and temperature play a part in the spread of the virus?
Those are two good questions. The virus is not spread through blood.
Okay.
All right, it's an airborne virus.
Okay.
So will they have an event below the equator as they approach their cold and dry seasons? It's possible.
Yeah.
I don't think anybody is speculating on that right now. I know that they are, as part of the whole globe, the world is now considered, no matter what, one world.
Absolutely.
rapid translation from place to place, populations constantly on the move, and a germ like a coronavirus is a global virus. You know, it's just likely that will be part of the hazards that lay ahead. Perhaps we'll have something to stop it before then.
Yeah.
As a treatment or preventative, but we're still not quite there.
Right. Well, and the next question was, I think you talked about this a little bit in the first video, but weather and how that affects the cold or potentially the coronavirus, or because somebody else also asked to come, so maybe talk about like weather and how that affects it, and also how this might become a seasonal thing.
Those are good questions too. The cold and flu season corresponds to the time of the year when we get not only colder, but drier. Cold air does not hold moisture, which tends to desiccate the mucous surface. That's why your lips chap in the winter.
Right.
It's why you bleed. Your nose may have a tendency to bleed in the winter. But that chapping, that change in the hydration level of the body contributes to damage or injury to a surface that, if it's not intact, will allow things that are resident on it, like a virus, to have easier access to the tissues beneath. Once that happens, you start a cold. Okay. Whatever it may be, whatever the agent may be. In the case of the coronavirus, it had certain other properties that impacted on cellular metabolism and cell pathology.
Right.
That's what effectively turned this from a common cold into something more aggressive.
Right.
Now, having said that, the process of winter is not unique to the harm done to the respiratory tract, but it contributes to it. And it contributes to an environment where one person gets infected and then another person gets infected, and before long you have this kind of horizontal spread of an infection to everybody who's susceptible. Now, people with an immune system response from a previous exposure will be less likely to have a big bad outcome.
Right.
So what is likely to be the longer term evolution, as more and more people are recruited into the exposure pool, there'll be more and more people that have some immune language, some antibody legacy that will enable them to fight it off or attenuate the disease. Right now you're dealing with people who haven't seen this kind of virus before, so the most susceptible and the most vulnerable are getting sick.
Right.
That's not likely to happen again, even if it comes, as is likely, a seasonal virus. Almost all of us know that winter is cold and flu season.
Right.
And there are some things we can do about it, and there's a lot of things we can't.
Right.
But putting up with something is different from actually addressing it. And right now we're in the put up with it phase, rather than do something about it phase.
Right.
Hopefully the do something about it phase is going to happen soon.
Right.
Statistical assessment is at best a numerical guess.
Right.
You know, it's how many times your bread with the peanut butter is going to land on the floor when it falls. It's, you know, you can drop it X number. I know for me it's going to be always peanut butter side down.
Right. There you go. Yeah. Exactly.
But giving it a numerical value that this is going to happen X number of times over X number, over Y number of days, and over...
It's impossible to tell.
That predictability, if it were built into this, well, I guess you wouldn't have to worry about the lottery, because you could do it at the, you know, you do it every time.
Right.
So we have to look at that. Now, as far as...
Okay, what is the likelihood of catching the virus from getting takeout food delivery from your local pizzeria or restaurants?
Highly improbable.
Highly improbable.
But I'm never going to say never, because that would not be. But if you're getting cooked food
Right.
and it comes in a box that human hands don't touch.
Well, what if the human hands are touching it though?
Yeah, you have to know obviously where you're getting your food from.
Right.
But I wouldn't be afraid of takeout food. There is, again, its amount of viral burden and how it's delivered should be through the respiratory tract. And unless you're snorting your pizza, I don't think you got to worry about that.
Well, what if, say, hypothetically, someone in the restaurant who's cooking it doesn't even know they have it,
Right.
and they cough on it?
No, it's an appreciable risk. It's a measurable risk, but probably pretty low key.
Okay, I mean, I would.
I think pizza's going to be heat treated.
Yeah.
It's going to be cooked.
Yeah.
So
yeah.
that element, even if there is somebody nearby that might be shedding some virus, is probably pretty safe. But again, you have to know where you're getting it from and what you're doing. I don't think it's zero, but I wouldn't put a number on well, that's probably a 12% risk.
Right.
I wouldn't do that.
Right, exactly. Well, the way I see it is like, okay, I'll get takeout, but only if I can heat the food up, you know?
Yeah, and if you know the source. I mean,
right. Okay. If someone catches coronavirus and then recovers, are they immune now? You might have answered this question already.
They will have had, if the recovery implies that your immune system has taken care of business.
Okay.
So it will leave you with a legacy. We can use the term "you're now immune" or "you don't have to be concerned." That's a point of discussion that's still being studied.
Okay.
But I would say the likelihood is it was because your body, not because of any outside agent or chemical or drug or anything else. You got over it. It means that your system can handle it, if you will.
Okay.
But again, how long will that immunity last? How transferable is that immunity? How measurable is it? All of those things are questions that are still being asked and have not yet been thoroughly answered.
Okay, good to know. There's a follow-up for this. If so, which I think you also answered this, could their blood be useful in transferring immunity to someone else? Could we staff hospitals with immune people as volunteers and workers?
They're studying that.
Interesting.
They are studying, the gamma globulin reference that I did before.
Mm-hmm.
They're studying antibody transfer from patients who have recovered to the fairly critically ill patients who are still not quite getting through it. And they've had some good results, but it's not, study is ongoing, not complete, and the information is still kind of in the oven. It hasn't come out yet.
What about hiring immune people as volunteers at hospitals and places?
Well, I believe they're using people that have recovered as and approaching them for the source of the immune globulin.
But I even mean working there. Like, say they need volunteers, people to do
I see. No,
busy work.
I hear that's a different question. Sure.
Yeah. How is it that folks in China who were originally indicated as having COVID-19 are now testing positive again? Is that really happening?
I'm not familiar with that. I don't know what tests they're performing since there's PCR testing and antibody testing and a number of other ways of looking to see what the disease is doing, from culturing noses and so on.
And they're not explaining any of this.
So I really can't answer that.
Okay.
But somebody who has had COVID-19 and has gotten over it, this is, if I'm understanding the question, and then they're sick again from it?
No, they're testing
or they're
positive.
Just testing positive. I don't know how those tests are being performed or what tests they're doing.
That's a good answer. Okay. Ibuprofen versus, how do you say it? Acetaminophen?
What? Acetaminophen. Tylenol.
How do you say it?
Tylenol.
No,
Acetaminophen.
Acetaminophen. That is a tongue twister. Yes, Tylenol. So in other words, Advil, Aleve, Motrin versus Tylenol.
Yeah.
Okay.
There was
I think
this is the legacy of both improper and ill-advised opinion from somebody in government, and it happens to be from a French minister of health who didn't think it was a good idea, based on just his personal opinion, that you use what are called an NSAID, non-steroidal anti-inflammatory drug. The big category includes Motrin, ibuprofen. It also includes Aleve. It includes
Advil.
The non-steroidal anti-inflammatories, NSAIDs. In the past, especially in children, for example, there was a fear that the use of aspirin to address fever with the flu would lead to an entity called Reye's syndrome, which was a devastating side effect. So aspirin, in certain circumstances, was not an indicated drug to take care of fever, and indeed, acetaminophen, Tylenol, is a better anti-fever drug than even aspirin.
Than any of those other ones.
Right. Under the circumstance, since somebody came out with the warning, and it made its rounds on the web, and so it's now don't take Motrin if you have X, Y, or Z. In overabundance of caution, just if you don't need to use anything to address a fever, good. If you do, Tylenol, but make sure that if you do have a fever and you do have the cold-like symptoms and all the rest of that you let your healthcare provider know this, so that they can give you their input on what's best to use, rather than grabbing something over the counter to treat a symptom. That would be the way I'd approach that.
So that was okay. Have they gotten any closer to finding a vaccine or some kind of medication? And then this person followed up with I heard there was a study being done with people taking a combination of antibiotic and the medication for malaria. We've been talking about this a lot in our house, so maybe we should just talk about that here.
Okay, so that's really two questions.
Yes.
That's really a
vaccines.
The first one we'll go with is vaccine, and the second one we'll go with, is there a treatment that we can use? As far as the vaccine is concerned, there's certainly at least 7, maybe 8 different groups that are working hard at developing different types of vaccine. One in particular is genomic, where you recognize the gene structure that you're dealing with based on the RNA studies or DNA studies of the COVID. It's RNA studies, obviously.
Because it's an RNA virus.
It's an RNA virus, right? And they are very close to having isolated what may be something that the human immune system will recognize and produce a response to in the form of a non-viral vaccine, as opposed to a killed viral vaccine, as opposed to a live viral vaccine, as opposed to any of the other maneuvers that currently exist. There are forms of vaccine that are injected, forms that are ingested, forms that are insufflated or given through the respiratory tract. There's a lot of work going on right now. But the point really is it has to produce an immune response that's protective in nature, and that has to be tested no matter what the vaccine is. It also has to be tested for safety. It has to be tested for compatibility with other forms of treatment, comparing it to what we already have, if you will, in the armamentarium. The function of doing all those tests is to assure effectiveness, efficacy as they call it, as well as safety. That's not something you're going to be able to just
do overnight. Yeah,
and you have to have enough accumulated data to make a decision. But the work is ongoing, and there are several groups that look like they're very close. That's future file. No matter what you do, the time line to prove all the things that have to be proven to say, hey, that's a good vaccine,
Right.
probably won't mean something until, if we're lucky, next fall.
Jeez. Yeah. Wow.
Okay.
Yeah.
Well, if we are, then it'll hit at the beginning or before the flu and virus season begins. So not a bad thing.
Not about that. The second question.
The
was
second
about
part of it is about
medicine.
medication.
Yes.
There are, and these are anecdotal reports, but the anti-malarial drugs,
Right.
hydroxyquinoline is the one that has come up high on the scale. Hydroxyquinoline and its derivative compounds and its antecedent compounds have been around since World War II. They actually started in the mid-1940s because malaria was part of the process of fighting in the jungles of Malaysia and the Philippines and in the South Pacific theater. That it's an endemic disease, been an endemic disease as long as probably one of the oldest epidemics in mankind's history. Malaria has been around a really long time. The hydroxyquinoline prevents the virus from penetrating the cell and becoming resident or taking over the metabolic machinery of the cell that's infected, along with zinc and along with an antibiotic, azithromycin. That combination has proven effective. It's used routinely in India. It's been used in China. It's been used in Japan and in South Korea. It's been used in Brazil. Now, the Brazil model is interesting because it is a tropic and there is malaria. There's a lot of the population taking the stuff already, and they've had a very low incidence of COVID-19 and almost insignificant number of mortality, morbidity. So that's anecdotal, and it would be considered by our FDA as an off-label use of a medication, but it has worked, and it is seen as one of the answers that for right now, since we don't have any other answer, we don't have any other effective antiviral, and we don't have any other option, and could be used now.
Right, I've seen them talk about this a lot on the news. I mean, I'm sure you're reading this all in the medical literature, which is where that's where you got most of your information.
Most of it. The fact is, this is the unfortunate thing about COVID-19 from my perspective as a health professional. It's been politicized.
Yes.
So turn it into something against the candidate or for a candidate, and as part of a political posturing from people who have no medical background but who have harsh opinions and who have an agenda. They have an agenda. They're pursuing a specific narrative, and if they want to take the information, distort it, or impale it on with their own kind of political perspective, it stops this from happening. Because quite frankly, no germ has a return address. It doesn't care where it came from. Doesn't care who it's impacting. It doesn't care what your color is, what your race is, what your gender is. It doesn't care.
Yeah.
And the point really is, we need a solution. We don't need more screw ups.
No. And is there anything folks with chronic asthma should do to lessen the impact of getting COVID? Or if they do get it, any way to mitigate the risk to lung function?
That's a good question. That's a really good question, actually. And there's good news and bad news.
Okay.
That sounds like a joke, right? Donkey walked into a bar. No, the good news is that almost all of the anti-asthmatic inhalers and the treatment for a reactive airway, they're safe for use, and there's no need to interrupt what you do to keep your lungs from becoming hyperactive. The American Academy of Allergy and Immunology, and Allergy, Asthma, and Immunology, they put another A in their name.
It's for the breathing in.
but they've done a fairly good job of evaluating anti-asthmatic,
Good.
especially the inhalers,
Good.
and have found that the steroid inhalers with the bronchodilators do not increase your risk from COVID, and indeed, by keeping your airways from becoming overly inflamed, you're actually producing good benefit. Now, the bad news is that you're in a high-risk category.
Yeah.
And that means you have to exercise great diligence. That's the patient who, in my estimation, shouldn't go out without the mask. They should be wearing the gloves and stuff like that. Might feel like overkill, but you can't be too safe.
Yeah.
And with anything that increases your vulnerability, and the underlying vulnerability is chronic lung disease.
Right, like
that's what asthma is.
Right.
And that's one of the categories that has been impacted to a greater extent than those who don't have that. So stay on top of keeping your asthma under control. At the same time, you can significantly hyperhydrate, lots of fluids, yellow, green, and orange fruits and vegetables. You have to be on top of your rest pattern. Don't take anything for granted as far as your personal health and hygiene is concerned. And that plus proper, forethought. Don't expose yourself to something. If you have a doubt, then don't do it.
Yeah.
But that would go along with it. But
a lot of your patients are going to be happy to hear that because they've been wanting to hear that for you for a while, Dad.
You think?
Absolutely.
Okay.
I know they're all going to comment on this video and say thank you. So that's very good advice.
Stay ahead of all of your health parameters. Make sure you can care yourself.
Yeah, good advice. That's good advice to everyone. Is there a reliable set of symptoms? I feel like we may have talked about that. Had a friend who tested positive with no fever, another lady with lungs that were filled with fluid and no symptoms prior. Can we expect that the symptoms will continue to vary drastically?
The spectrum of individualization is the same in disease as it is in health. Some people can run fast and others can't. So if one, and I'm not trying to downgrade, that's actually a good question, because it's asking how variable is the manifestation, not how variable is the disease. Well, the manifestation depends a lot on the biology of the patient and what actually is going on. How a woman, anybody for that matter, would fill up with fluid and be asymptomatic, that's a conundrum. That's really not, there's something wrong in my estimation with that picture. So is there an underlying pulmonary fibrosis that picked up on x-ray and they said, oh, you're full of fluid, but she's not got a cough, she's not producing phlegm, and you need more information to give an explanation for that. And somebody who has a positive test and is asymptomatic, well, there's another sort of, where are you on the spectrum of the event?
Right.
Is it early, middle, or late?
Right.
Did you have symptoms and they didn't strike you as significant enough to program it? Or are you going to have them?
Right. So
there's not really enough meat in that question to give a solid answer. But everybody individualizes. We're heterogeneous when it comes to that. Some people can tolerate pain and others, they can't stand to have their nails cut. It's,
That's a great answer.
Okay.
I think that's such a good thing to remember, though, because I think as people who, we don't go to medical school, we're not medical experts, we don't understand the pathology of what's going on in our bodies. We forget that this is not just an, equal sum game. Just like you said it, some people are fast, some people are slow. Some people are tall, some people are short. That all has to do with our chemistry and biology as well in terms of how we respond to viruses and germs. And those are not things that we're ever taught or that are ever explained to us, especially in a situation like this where, again, we're getting hounded with all this misinformation and the government and media telling us, oh, it's going to be this way, and there's no understanding of how this all works. Can my cat get sick?
Actually, coronavirus in animals, even if it hasn't switched to humans, can be lethal for dogs, cats, cattle.
The tiger died.
The tiger died?
There was a tiger at the Bronx Zoo that died.
I know that they tested positive.
Oh!
I
Maybe
didn't
he
know
didn't
it
die.
died.
Maybe he didn't die. Someone. Oh, I read on Facebook someone's dog died from coronavirus.
Coronavirus in animals can be devastating. Yeah.
Jeez. Okay.
But in fact, they think that it's a zoonotic, meaning a veterinary disease first go, and we happen to be secondary rather than primary targets as hosts. That may no longer be the case.
Okay. 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 So this is the last question. Someone said, I'd really like to hear his suggestions on ways for lay people to follow the virus that are as low sensationalist as possible. So where can people go to get just facts and not have all this sensationalism surrounding it?
I would have said go to the NIH or the CDC.
Okay.
But that was 4 weeks ago.
Okay.
And I don't know how you feel about it, but the more I hear, the more of the statistical probabilities and predicting and talking heads I hear on television, the less I feel confident that I'm going to get unbiased information.
Yeah.
The example being the Surgeon General telling us why we shouldn't have any masks and quoting the World Health Organization, and then 3 weeks later reversing himself. It's hard to maintain a sense of balance with that.
I think they really know they messed up with that. They really realize that they shouldn't have hid that from people.
Well, even if you look at the projections for the morbidity, mortality, how many people would die, and how high they set that risk pool, how many millions were going to die.
Right.
And we're seeing a bad outcome. I mean, people are dying, and a single death, and especially when you watch any of the news or go on the internet, every death is a dramatic event, especially if it's a child, or especially if it's in the setting where an entertainer gets it. So, having said that, what is the best source of information? And I think what you have to do to get good facts on this is check in more than one place. In other words, try and cross-reference it. And if you hear something that sounds terrible, find out what the source was for that information, especially on the internet. And if you can't find it, put it out of your head, because it's probably not true. I go to the National Library of Medicine, NLM.
Mm-hmm.
There is a website.
We're gonna list these too. Also, we can list them. I'll post them in the video. Yeah. Okay.
But I always use the National Library of Medicine, because when you pull an article that has made its way into that literate pool, you're going to get good information. And then they always have a long list of cross-references, so you can go through the cross-references and see it. And if it's an opinion piece, put it aside and go back to the science. Don't believe anybody's opinion.
Yeah, you sent me that one hot topic.
Yeah, but how to dissect what's good information from what's bad information? We're all swimming in a sea of lies.
Yeah.
It's hard. It's really hard to accept some of the ethics of what's going on. But besides that, there are ways of getting back to the cross-referencing.
Yeah.
And that's all I would do.
Yeah, absolutely.
Okay.
Great. Well, and obviously we want to say, of course, thank you to all the healthcare professionals and nurses and doctors out there on the front lines, because they really are doing...
Everybody stay healthy, stay strong.
Yeah, of course.
Happy Easter and happy Passover.
Yeah, happy Passover. It happens to be Passover tonight when we're filming this, so... Yeah.
Okay.
All right. Thanks, Dad.
You're welcome.
Okay.
Thank you.